Hello everyone, welcome to our Zoom meeting. Today we will have different topics that Omar and his team will be presenting. Please, when you are ready, you can go ahead. Thank you, Dr. Omar. Thank you, everyone.
Hello, thank you, Dr. Nader. Today's meeting, the agenda we have is nutrition and diet in older adults. It will be presented by Dr. Ayat. And next we'll talk about the use of Mendeley for referencing and citation. It will be presented by Dr. Ola Ali. The third agenda is going to be about the 5 best electronic health records software for medical practice management. It will be presented by Dr. Makkawi. And finally, we'll talk about future of AI in medicine by Dr. Malaz Salah. And in the end of that, we'll talk about the board certification in internal medicine. I think that is replacing the usual updates about research projects. We will start with Dr. Ayat Hamdan. Are you ready? Yes, I think she is. You can start right away.
Dr. Ayat, I think you are muted. Thank you.
I have to text her. I think she does not hear us, maybe. You are muted, Dr. Ayat. Probably she logged out to log in again. Maybe she has a problem, technical problem with her microphone.
Sure.
I'm really sorry. Out of nowhere, my connection was freezing. So let me just open this one. Okay. I think I can see my screen. Everyone is seeing my screen clear?
Yes.
Good. So, hello everyone. My name is Ayat Hamdan. Good afternoon. Today I'm going to present a topic about nutrition and diet in older adults. It is a little bit condensed, so I will try my best not to dig into the physiology and all of the mechanisms behind it. It will be just for clinical part of the nutrition and diet in older adults. I have no conflict to declare. Our objectives will be to talk about the nutritional assessment, what is well-nourished individuals and how to deal with those individuals, what is malnutrition, how to diagnose, how to evaluate, and how to manage, and then a little bit about the micronutrient deficiency as well as failure to thrive in geriatric patients. To start with, we need to understand why this topic matters. So if we want to talk about the prevalence of nutrition-related conditions, and mainly the malnutrition and undernutrition, a 2016 meta-analysis showed that in various care settings, so they took 240 studies over 110,000 patients, and the rates of malnutrition on those older adults were as follows. In the outpatient setting, 6% of the patients were having some sort of malnutrition. In the hospital setting, 22%. In nursing homes, around 17.5%. In long-term care, 28%. And in rehabilitation settings, the percentage were around 29%. That is so significant. So especially in the long-term and rehabilitation settings, because that means out of 100, we have like around 30%, 30 patients having some sort of malnourishment. Another data from studies of acute hospitalization showed that in older patients, up to 71% are either at nutritional risk or already are malnourished. This is why we need, why the importance of assessment of nutrition and diet. Bodies like the American Academy of Family Physicians and the Canadian Task Force recommend that clinicians routinely provide nutritional assessment and counseling for their patients in each and every single visit, or somebody suggests that's done biannually or even annually. How we can do that? We have many tools. The most important tools, or the simplest, is the malnutrition screening tool, and the other one is the malnutrition mini nutritional assessment tool. So I will just show you both of them, how they look like. Just one minute. So for the malnutrition screening tool, it's simply 2 questions. The first one is asking the patient if he has lost any weight recently without trying. And the main key here is, like, the emphasis is without trying. So if it was voluntary or controlled or desired weight loss, that is not counted. Other than that, any unintentional weight loss is counted. And the points are based on how many kilograms the patient lost. So if he lost like 1 to 5 kilograms, this is 1 point, 6 to 10 kilograms, or he's not sure, those are 2 points. 11 to 15 are 3 points, and anything above 15 is 4 points. The other question is, have you been eating poorly because of decreased appetite? Yes is 1 point, no is 0 point. Anything that is 2 or above, so here is scored 2 or more, that means this is positive screening, and we need to dig a little bit more about the nutritional status of this patient. And then the other one, it is not as simple as this one. So this is the one that's adopted by American Academy of Family Physicians. This is 18 questions, so it's a little bit lengthy, and it has subsections. So the first one is the anthropometric assessment, taking in consideration 4 parameters, and the main and foremost is like the body mass index. We know how to calculate it, weight in kilogram divided by height in meter square. So what is the body mass index of the patient? What is the mid-arm circumference and the calf circumference? And to add on, because sometimes the patient, his baseline is slim or underweight, so we need to ask about the weight loss in the last 3 months. So even if the patient is slim and he still lost more weight, that is considered something worrisome. If he is maintaining his weight, it's a good thing. But still, there's some sort of intervention that we need to do so he can maintain his weight in the long term. Other questions will be the general assessment. This is another section. We will ask about living independently, taking more than 1 medications per day, if he's struggling with any psychological stress or acute disease in the past 3 months, his mobility, his neuropsychological problems, and if there is any pressure sores or skin ulcers. And this section is important because when we come to differentiate between malnutrition per se and failure to thrive, we will find that failure to thrive is a combination of weight loss plus some sort of disability and loss of daily activities, as well as some neuropsychological or even cognitive impairment. So for this part, it is important to ask each and every single question. The dietary assessment is where you are trying to figure out where is the problem. Like if he's taking a full meal, how many full meals he's taking per day? If he's taking enough protein, if the patient is struggling from loss of mass weight, then we need to find out if he's taking the suboptimal protein or if he's taking enough protein just to maintain his muscle mass. Another question is if he's consuming fruits and vegetables. If there is any decline in food intake, that is loss of appetite. And again, this is the same question from the malnutrition assessment tool, because in that questionnaire, we ask about the diet and loss of weight. Here is the question about the loss of appetite, I mean. Another question is about the fluid, if he's taking enough fluids. And what is the mode of feeding? Why we're asking about the mode of feeding? Because for some patients, they just have dysphagia or they have feeding problems that we need to be aware of. And sometimes they might require a referral to speech therapist or someone to just help them with the swallowing process. The last question is the self-assessment. And this is basically you ask the patient, do you think you have a nutritional problem? And do you think, how would you rate your overall health? So the maximum points are 30 points. Any points above 24 is considered a good, and we don't need to do anything. We just need to, again, in the 6 months visit, we need to review again. Otherwise, we don't need to do anything. Any points at less than 17, that means the patient is malnourished, and we need to intervene to figure out the cause, and we try to help the patient as maximum as possible. Between 17 and 24, we consider him at risk of malnutrition, and as well, we need to act on that. So going back to our assessment, mainly 2 tools. If you don't have those tools, or sometimes with the basic clinic, you can't ask those questions, it's okay. Just go over the vitals and see if there's any recent weight loss. If no, it's okay. If there is a weight loss, you might want to go in details about those tools and other steps we will mention. So if the patient is having no weight loss, no decrease in appetite, everything is fine, that means he is well nourished or overnutrition. If he is overweight, we need to go ahead and talk to him about his overweight and obesity and how to target the obesity, and it is related to comorbidities. If he's maintaining his weight or a healthy weight, we just encourage him to take a healthy diet. And healthy diet is basically he's taking a variety of foods that meets the recommended dietary allowance for nutrients. It is very much similar to that of the healthy diet of a younger adult. There is some website that can help. I will just show you one of them. That is the U.S. Department of Agriculture. It's called My Plate. Let me just show you. So in this website, there's multiple sections. If you come to life stage, you will find some sections for pregnancy and breastfeeding women, infant, toddlers, preschooler, kids, etc. And their main focus is also older adults. So you might refer them to such website. Just in this website, they will see what is the eating, the healthy eating habits, what is the nutritional tips, how to be active, and there is some mobile phone application they can download as well, and they can link it to Alexa if they have Alexa at home. That will help them in determining what they need to eat and what they don't need to eat at this stage of their life. If they still struggle and want professional advice, you might as well refer them to the dietitian or nutritionist just for a professional advice if they need any. So what is the malnutrition? To define malnutrition, it is a little bit complicated. So we will take one of the definitions based on the Global Leadership Initiative on Malnutrition. This was initiative in 2018, where they introduced a diagnostic criteria. The diagnostic criteria is based on 2. So we need at least 1 phenotype criteria and 1 etiological criteria. If I'm going too fast or if there's any questions, I will try to look in the chat. Okay. So what are the phenotype criteria? Those are 3 criteria. The main and the catching one is the weight loss. So the weight loss needs to be non-volitional, that is mean involuntary, undesired, and unintentional. The patient is not intending to lose weight. What is unintentional weight loss that should concern you as a provider is if this older adult is losing more than 5% of his weight within the past 6 months or more than 10% of his weight beyond 6 months. The other phenotype criteria is if he have a low body mass index, that is a BMI. The cutoff, if he is less than 70 years old, it is 20%. If he is more than 70 years old, it is 22%. So you just want to check his BMI. And again, when you are judging his BMI, you need to also compare it to when he was younger adult. Is it the same BMI? Is he losing more? And if it is the same, still there's some intervention that you need to do, because we are expecting him to lose some weight as he's getting older. So we want to prevent losing his muscle weight and instead focusing on losing fat weight, even if he is obese. The last one is the reduced muscle mass. So whenever the patient comes in with calorimetric, like paper or prescription, and said there's a reduction in his muscle mass, then we need to consider this as one of the criteria of malnourishment. So we need at least one of the phenotype criteria and one of the etiological criteria. So the etiological criteria is reduced food intake. And reduced food intake, mainly what they mean here is due to loss of appetite. So if he is decreasing less than 50% of his energy requirement for 1 week, or any reduction over 2 weeks, we consider this as one positive criteria. If the patient is diagnosed with any chronic gastrointestinal condition that can adversely impact his food assimilation or absorption, this is one of the criteria. And if he has any underlying inflammation, either due to acute disease, injury, or chronic disease. So we need one of the etiological criteria and one of the phenotypic criteria to diagnose him with malnutrition. And if we talk about the weight loss, why we are concerned about weight loss in geriatric patients, it is mainly because they have certain sets of situations that will make them more vulnerable and more susceptible to have weight loss. It can be mainly social factors, physiological factors, plus or minus medical factors. So what are the social factors? The first one, and when we talk here, it's mainly the studied one. So for older adults in US, there's increased likelihood of isolation at meal times. And they did several studies that demonstrated if older adults eat in the presence of others, they consume more than eating alone. So if he's isolating himself, if he's not sharing his meals with anyone, this is one of the factors that can lead him to eat less. The other factor is the financial burden. Some adults, they have fixed income, and with this fixed income, they rather spend it buying their medication or paying some bills than focusing on getting healthy food and just increasing the fruits, their vegetables, and eating balanced meal. The other cause is the physiological cause. So I'm trying not to mention the physiological cause in details, but if you need any further clarification, just let me know. The first one is age-related decrease in taste and smell sensitivity. So I remember my dietitian, she kept telling me about mindful eating, that you need to smell your food, you need to taste your food, you need to see your food, then eat. That will make you more mindful of what you are eating. For older adults, they lose or there's a decline in their sensitivity to taste and smell. So they really don't taste food as younger adults or smell it the same. The other factor is they have delayed gastric emptying, they have early satiety, and there is some sort of impairment in the regulation of food intake. The other thing that happens with aging is anorexia, which is decrease in appetite. It is influenced in older adults. That is mainly by multiple physiological changes, as well as there is decrease in food consumption as we age. So for older adults, they tend to consume less than younger adults. And if you think about it, it is mainly because their physical activity is reduced, the resting energy expenditure is reduced, and there is loss of lean body mass. So your body is adapting to decrease physical activity, to decrease resting energy expenditure by decreasing your appetite as well. There's another term that we need to also be familiar with. It's called sarcopenia. And what is that? It is a syndrome where we lose muscle mass. We lose the muscle strength, we lose the muscle performance. And it is merely a physiological phenomena. So there is no illness required for a patient to be sarcopenic. Sarcopenia is associated with increased rate of functional impairment because we are losing our muscle strength. So we are losing our function of the muscle. We sometimes they develop disability out of losing this muscle mass. They can be vulnerable to fall, and it increases mortality as well. And it's most importantly, it's not related to weight, meaning sometimes we have sarcopenic obese patients. Sometimes we have it even with normal weight or overweight. It's not related to BMI. It's mainly related to, I will just tell you, it is mainly endocrine changes, activation of pro-inflammatory cytokines, reduce alpha motor neuron units in the spinal cord, decrease physical activity, and to add on the suboptimal protein intake. So it is mainly physiological things in addition to the patient not eating enough or not consuming enough protein. Another and a similar thing is cachexia. So sarcopenia is when you lose your muscle mass physiologically, you don't have any illness. Cachexia is the opposite. You lose it because you have an illness. So it is a complex metabolic syndrome associated with an underlying illness and characterized by loss of muscle, plus with or without loss of fat mass. The main loss is for muscle mass rather than the fat mass. If the patient is losing fat as well, still he is cachexic. Why it happens? It is a combination of anorexia, inflammation, insulin resistance, and increased muscle protein breakdown that is frequently associated with cachexia. Cachexia impacts the intake of gastrointestinal function, so poor nourishment is more common in patients with cachexia. Rather than the sarcopenic patient. The sarcopenic patient might have like good nourishment. They are not losing weight, they're just losing muscles. Losing weight, but not too much weight. For cachexia, it's associated with increased morbidity, and it is just imbalance between the catabolism and anabolism of the body. There's setting of underlying illness that usually involves cytokines-mediated response. Which disease can lead to cachexia? The most famous are cancer, end-stage renal disease, chronic pulmonary disease, heart failure, rheumatoid arthritis, or AIDS. Okay, so as we mentioned, losing weight can be related to social factor, physiological factor, and medical factor. We have already talked about the social factor, physiological factors. If anyone has any questions, please speak out. Otherwise, we will just go to the medical factors. Okay, so for the medical factors, you need to think about a lot of disease. So it's really helpful if you decided to make it system-wise. So the first thing and the most important thing is malignancy. And just remember, while doing the nutrition, remember the screening of cancers due. If the patient is due for lung cancer screening, breast cancer screening, if he is due for any other diseases, please do that. Always screen for depression as well. So for the malignancy, lung cancer, breast cancer, hematological cancer, gastrointestinal cancer, genitourinary, ovarian, prostate, and hepatobiliary. For gastrointestinal diseases, mainly the peptic ulcer disease, dysmotility syndrome, cirrhosis, bacterial overgrowth, chronic pancreatitis, mesenteric ischemia, inflammatory bowel disease, and celiac disease. For cardiac diseases, remember heart failure, coronary artery disease, and unstable angina. For pulmonary, remember the COPD, interstitial lung disease, and bronchiectasis. Infectious, remember mostly all the infectious disease, but focus on tuberculosis, subacute bacterial endocarditis, if he has recurrent bladder infection, recurrent aspiration pneumonia. For neurological disease, you need to think about dementia. Not dementia per se, it is a significant cause of weight loss. People can forget to eat. So the dementic patient might just forget to eat his meals. For a stroke, he might struggle with dysphagia, or any source of like feeding issues. Motor neuron disease as well, and Parkinson's disease. Endocrine disease, remember, diabetes, adrenal insufficiency, hyperparathyroidism or hyperthyroidism. Renal, think about uremia, nephrotic syndrome. Psychiatry, remember depression, bereavement, because if they lose like a loved one, they might as well stop eating. Alcoholism, mania, and psychosis. Always keep in mind the micronutrient. It might be so clear and it might be so ambiguous because sometimes they present with symptoms and sometimes they don't. Think about thiamine, vitamin B12, vitamin C, and zinc deficiencies. Lastly, think about rheumatic disease if you got any polymyalgia rheumatica, giant cell arthritis. So those are the mainly are the medical conditions that you might want to think about, but it's not limited only to those conditions. It will help you if you just print it in your clinic, so you just take a look at it and see history-wise what is the patient is pointing you towards. Another concept that we need to familiarize ourselves with is a failure to thrive. And as I mentioned earlier, there is section in the questions that you need to ask, mainly to make sure this patient is not having failure to thrive. He is having like purely weight loss. So how the National Institute of Aging described the failure to thrive? It is a syndrome of weight loss, decreased appetite, poor nutrition, as well as inactivity. That is often accompanied by dehydration, depressive symptoms, impaired immune function, and low cholesterol. In geriatric practice, failure to thrive is a syndrome of global decline that occurs in older patients as worsening of physical frailty that is frequently compounded by cognitive impairment and/or functional disability. So it is really a combination, and I really like this figure because it shows you to have a failure of thrive, you need to first the frailty, the weight loss and malnutrition, and poor physical function. You need to have disability, loss of one or more of activity of daily living, and the impaired neuropsychiatric function, like depression, cognitive impairment, isolation, grief, financial issues, abuse or neglect. Other thing that you need to keep an eye for is the medications, because sometimes patients will, for example, if he has Alzheimer and he's taking some medication that will affect his appetite, you need to be careful of and aware of those medications as well. So what would you do if you have a patient with malnutrition or a patient, as we said, well nourished? We will just advise on healthy eating, give him some resources. If he need a professional referral, we will do this. For those with malnutrition, so first of all, we will document there is a weight loss. If it is 5% or more over the last 6 to 12 months. If no, that's it. You just closely follow up the patient and just keep an eye on the weight whenever he is coming to the clinic for whatsoever reason. If he's having weight loss, then we want to take a full history. We already know now the causes or the main reasons why would some elderly patients have weight loss. We just need to dig into this history. We need to evaluate his if there's any eating disorder, if this weight loss is intentional or controlled, what is the pattern of weight loss, if there is any associated symptoms, is it guiding us toward a specific diagnosis or no? What kind of medication he's taking? What is his function and social factors? And if we didn't find anything, we need to do like a full examination head to toe just to know what's going on. And we will look for if there is any nutritional deficiencies, signs or symptoms. And then we will do a cognitive and neurological examination. If we have a suspected diagnosis, that's it. We will target our evaluation and diagnostic toward this diagnosis. And if we confirm it, that's it. If we didn't confirm our diagnosis and no further testing is needed, we'll just go back to screening him whenever he's coming and just to follow up his weight loss. If we don't have a suspected diagnosis, what the American Academy of Family Physicians recommend is those basic testing, but you might add on. So you need to do his CBC, his electrolytes, his hemoglobin A1C and glucose, RFT, urine analysis, hepatic function, thyroid, stool for hemoccult blood, just making sure he doesn't have any malignancies or inflammatory bowel disease. We need to do ESR and CRP, HIV and hepatitis C. And hepatitis C here is mainly if indicated. If we know this patient has received any blood products or he was born, I'm not sure about the age, is it like 1957 or something? I'm not sure. And if we need to do a chest X-ray, and then of course you do the age-appropriate cancer screening. If you find a diagnosis, that's it. You will target your management and further evaluation for that diagnosis. If you didn't, then you do a watchful waiting for 1 or 6 months. And then if you need a shorter interval, you will do that. If not, you will just pay attention whenever he's coming for dietary history, if there is any possibility of psychological diseases, if there's any medication intake that you need to be careful of. Okay. So if we make it as a scheme, it will be, first, you need to identify and treat the underlying cause if you find a cause. The second thing is you need to set calories and protein requirement. If you have a calorimeter at a clinic, you will just let him at least get the resting energy expenditure, and then you will calculate the protein requirements. Sometimes our patients, they don't know if they are consuming enough protein and how many proteins in grams do they need per day. So we need to tell them, well, you are eating good, but I think you need to increase your protein consumption, maybe introducing dietary products, maybe you need to eat more meat, etc. Another thing is you always want to engage a nutritionist. Why? Because individualized dietary counseling is always effective, and it's more effective than a generalized tip. The other thing is you want to do a dietary supplementation. So what is a dietary supplementation? Is basically you tell him, okay, so I think you might want to add a cup of milk in the morning if he's drinking like tea without milk. If he needs to increase his protein, so you can recommend some protein shakes or protein supplements. And then you need always to address his food intake. You need to know his habits. You need to know if there's any dietary restrictions. If he's vegetarian, he's not consuming meat, what other alternatives you need to, like legumes or eggs. You need also to be aware of his restrictions in terms of if he has celiac disease or any disease that will cause any trouble, lactose intolerance, any trouble with certain types of food. So this is basically the management. There is some medications, but it is always questionable if medications are of use just to increase the appetite. In general, they don't recommend you to start him on appetite stimulants or any other stuff. So you really need to focus just on those items as well as treating the underlying cause. A little bit of talk about the micronutrient. Only 2 slides left. So for the micronutrients, you need to be aware of vitamin B12 deficiency. It has higher prevalence in older adults, around 10 to 20%. Vitamin D deficiency as well, especially in the individuals who are not seeing much of sunlight, like institutionalized, homebound, have limited sun exposure, obese patients, those with dark skin, osteoporotic, or any patients with malabsorption syndrome. You need to keep in mind that you follow your practice guidelines in terms of monitoring vitamin D levels. Some would recommend annual. Annual is reasonable, but some might require like every 3 months or every 6 months. Always the goal is above 30 nanogram per milliliter. The last one is calcium. So individuals between 70 to 90 years of age actually absorb 1/3 less calcium than do younger adults. So you need to keep those 3 micronutrients mainly for older adults. So what about multivitamin supplementations? We all love to prescribe some multivitamins. My dad is taking a lot of multivitamins and my mom as well. And although it is a common practice, there's the available evidence has very weak evidence of benefits for taking multivitamins daily. And in some occasions, it might also lead to some drug interaction, patient doubling the dose. So we really don't want to do that. Instead, we will just recommend if you want to take calcium, you can take it from food. We can give some charts, which food is enriched in calcium, in vitamin D, in vitamin B12, etc. So basically, this is what I have for today. Thank you, everyone. Just stop the share. That's it.
Thank you so much, Dr. Ayat. That was really comprehensive and it was really extensive. Thank you so much.
Welcome.
Does anyone has any questions?
Thank you so much. This is a great presentation. Thank you.
Thank you, Dr. Nader. Appreciate it, everyone.
If there is no questions, then we can move on to the next topic. Dr. Ola Ali, she's here. She will present to us how to use Mendeley, and Mendeley is a famous tool used for referencing and citation, just like EndNote. Dr. Ola, are you here?
Yes, is my voice is clear?
Yes, it is clear. If you're ready, you can start right away.
Okay.
Okay.
You can see my screen, right?
Yes, now we can see your screen. It's very clear.
Okay. Hi, everyone. Thank you for being here today. I would like to start by thanking Dr. Nadir for giving us this learning opportunity and thank everyone for the attendance. Today, I will be talking about Mendeley and I will be showing how to use it to manage referencing and citation in a practical way. By the end of this session, I can promise you, you all will be able to add references, organize them, and use them in Word without struggling with formatting. Mendeley is a very easy tool to learn and to use. Here I am at Mendeley website. I will start from here. This is the main page, and as it describes, a free all-in-one reference manager. It is free to use and it is really all-in-one system. It includes a web library, a desktop reference manager, and a Word add-in. You can use it online on the Mendeley website, Mendeley Referencing Manager web, or you can download the desktop version. But it is no longer updated by Elsevier. You can download it if you would prefer to work offline, but the website is more than enough if you can work online. So to use Mendeley, the first thing you need to do is to have a free Elsevier account. The registration is straightforward. You just enter your password, email, and that's it. Then once you logged into your account, everything will start to sync in across devices. Now from here, I will click here and to get started with Mendeley. Here we can find the reference manager. This is the main page. Here I can find all my references here to the left, or I can organize them by whether I can filter them by whether they were added recently or read recently. I can find my publications here. I can find those I made as favorite, and I can also check for duplication. Here in the middle, they are all the references. And when I click on a certain reference, I can find its info here to the right. From here, we can search the whole library by any part of the reference information, whether the title, the author, or so on. And we can filter the references we have by the authors or by tag we have already set. Okay. Now, let us start with the first thing we need to learn how to do is how to add references. By clicking at add references, we can see here that we can import files, we can import folders with multiple PDF on it, or we can import another library from another referencing manager like EndNote, for example, with all its data. And the easiest way to do that is simply by dragging a PDF like this. Okay, if we didn't get it from here. When the PDF upload, you will notice that the Mendeley has read all the metadata attached to the document, and you will see all the information of the paper automatically appear. But you always need to double check whether all the information are correctly read by Mendeley or not. So another way to add references is manually from here, but it is a quite tedious way by writing a title, author, and all the information. Or we can use identifiers, which is the DOI or PubMed ID or so on to retrieve the information of the paper. For example, I have this paper here. I can copy its PubMed identifier and go back here to Mendeley, paste it here, look up for the metadata, and as you can see, all the information of the paper has been read by Mendeley, and we can add it. This is the same PDF I has just added, but here it's appear with its file or a PDF. Okay. Another incredible feature of Mendeley is, as you can see here in my browser, this is Mendeley logo, which can be added as which is a web importer that can be added as an extension for your browser. To add it, you need to go to extension for Microsoft Edge here or whatever browser you have. I guess it's work for multiple browsers like Chrome and I don't know, but it's work on multiple browsers. I'm not sure. And when you attach the extension, and open it at any journal page or on PubMed, for example, like now. You can see it has identified all the papers in this web page, and you can just click on them and add them to your library, or you can even add them to a certain collection or group in your library in a very easy way. And if there is any of the data has been retrieved wrong, you can edit it on the spot and then add it. Even if you were on a web page and you want to reference it while you work, you can find at the end the web page you are on here with the date you have accessed it, and you can also add it to your library. Now back to the manager. Here we have the paper we have just added, and you can see this blue circle here. It indicates that this PDF I didn't open yet, and I didn't read. From here, we have the collections. The collections are basically a way to organize your papers or your references. We can create collections from here. Let us say that I will create one about frontotemporal dementia, as those papers are about, and then to add them, I just going to select them, click organize, add to collection, and select. As simple as that. We can also add them to group or mark them as read, unread, favorite, and favorite. We can also, with the same way, export our references to EndNote or in any of these formats. To tag, to add tags for our paper, for our reference, we can click on it, and here to the right, when you can find here tags, and you can add the tags you want. For example, like this one. By clicking at the file here, you can access here to read the paper you have, and from here you can read the paper, you can add animations, you can add highlights and whatever you like, and you can download it or export it with all the edits you have made. And while you read it, there is a notebook here. You can use it to add any notes you have. From the same area, you can also access the information of the reference or the paper you are working on or you are reading. It stay open here like this unless you close it while you are still working on your library. The last feature here I want to talk about is groups, which is a really great feature of Mendeley, because you can create a private group that include up to 25 members. And in this group, all the members can share the same references and share the same PDFs and can work on the group together. It is quite a useful feature. And to create a group, it's quite simple. You would create a group and add the references to it, as we have seen just by selecting them. And then you would have the members you want emails and add them. The groups you have created, you can delete or rename and manage, but those you were added to, you can only manage or leave if you finish your work or so. Now, I will move to Microsoft Word. It's where we can use Mendeley for real. Now, say this is a paper we are working on, or this is a document. We want to use Mendeley to add our referencing and citation. The first thing we need to add is Mendeley site. It's an add-ins. We can find it here. Click add-in, and you need firstly to add it to your Microsoft Word by searching it and adding it. And I already have it here. I can access it from here or from references here. Then by clicking on it, it's appear on the right side like this. I can see my whole library here with all the references I have. I can see the recently added papers that we just added now. And I can see my collections, I can see my group and everything. So after adding Mendeley to your Microsoft, as we have said, just from the add-ins, you can work. And the first thing we need to learn is how to insert a citation. Say that I want to cite this sentence here, and from this paper, I would put my cursor here and select the paper and just click insert citation. As you can see, here the citation has appeared. Say that I want to cite more than one paper at the same time for the same sentence. I can select more than one and just click Save Changes. And as you can see, the two papers has been cited here. Now to the bibliography. Here I have this headline, references, and I want to insert my bibliography below it. I just go here below it and go here for these 3 points, click on it and click insert bibliography. Here, as you can see, the references list has appeared with and have been automatically generated. If I add, remove citation, if I removed or add any citation here, this list will be changed. For example, if I deleted this one, save again, you can see the list has lost one of the citation. So this is basically how to insert citation and add a bibliography. Now let us say that we want to change the citation style. Now it is set for ABA or American Psychological Association style. Just from here, citation settings, we can find change citation style, and we can change it to Vancouver, for example, or any other journal-specific citation style. For example, if you want to submit your paper to a journal and it's require you to change your citation to a specific style, it's an easy process. When you are using Mendeley, just you will update citation style. And you can see it has been updated for the document. Here, regarding the bibliography, you can see it's set as lively updates. So this may slow down the device sometimes or makes the document lag. So if this happens, you can go here for more option and set it to manual update. This will stop the bibliography from updating while you work on your document, and when you finish, you can update the bibliography for the whole document. Now for the last thing and the most important feature for Mendeley, I guess, it's the collaborative workflow. If several people are working on the same Word file and they have access to the same Mendeley group, the Mendeley group we have just talked about with where people can access the same PDFs and the same references. If the same group of people have access to the same Word file and the same Mendeley group, then any one of them can manage references, and each person can write their part, insert citation, and everything stay consistent. For example, let's say I was writing the introduction section and I use this reference, and my colleague was writing a discussion section and use the same paper. So if each one of us use this paper and write his own references, it may be duplicated in the references section. It may not appear in the right order. It appears in the whole document. So while we are working together, we can just make the referencing processing together, and Mendeley can combine all the references into one bibliography if we already was working on the same group. This usually makes the collaborative writing much way easier. So this is the basic workflow of Mendeley. Once you get used to it, it's move a lot of manual work from the academic writing. Thank you, and I hope everything is clear. If you have any question, please don't hesitate to ask.
Thank you so much, Dr. Ola, for the presentation. Mendeley is a very good tool. I have used it, and it's almost as good as the other tools. Thank you so much. Next topic is going to be about the use of AI in medicine, the future of use of your AI in medicine. It will be presented by Dr. Mohammed Makkawi. Dr. Mohammed Makkawi, are you here? Okay, I'll try to contact him.
Hello, can you hear me?
Yes, I can hear you.
Yeah,
Are you ready?
my presentation is about electronic health record software.
Oh, I'm sorry. I'm sorry, Dr. Makkawi. Yes, it's about the best electronic health records. Yes, I'm sorry.
It's all right. I just wanted everyone to know. Just let me share my screen.
Yes, you can share your screen.
Okay. Hello everyone.
Yes, we
My
can.
name is Hello everyone. My name is Dr. Mohammed Makkawi. I will be presenting my presentation about the 5 electronic health record software. There are actually many more, but these are the 5 commonly used ones. So you may be wondering, we are all doctors. Uh, so why should we learn about software? Well, it's mainly some of us maybe in the future may decide to open their own practice. So so one of the things when you're trying to open your own practice is to compare which software would you use in your own practice. So hopefully once when we finish, we can get a brief idea about them. So what are they? Basically, they are. So usually, here for those of us who have worked in Sudan knows that when we are trying to record our patient information, we do it in files, in physical files. We will write down the patient's history, examination findings, and lab investigations, and keep them in a file, a physical record file. However, in many of the Western world, all of this is registered in electronic digital recordings, and we use this medical electronic health record so that we can keep them, and other people can also be able, those who are licensed, authorized, will have the ability to also see the medical records of the patient rather than just faxing over files and copies of patient's files which may breach patient confidentiality during the process. So one of the most commonly used one is known as RxMT. It's a cloud-based integrated software where with this particular one is one of the most commonly used, and it helps you give a tailorized software depending on your practice, how big it is. So if you're so they can give you one customized based on your needs. If you're either you have a small clinic or you have a large hospital, or if your practice is a specialized, for example, if your office is pure cardiology, they can provide you a particular software just for cardiology or for any other subspecialty as needed. And then they also have extra services such as telehealth. They can help in prescriptions or billing of for the patient's insurance. So if you can check their website, they can see this. You can also book a demo, and the pricing actually varies depending on, like I said, they tailor it depending on what you need. So if you have a large hospital, it will be different from someone who having a office-based practice. So another one is known as Ensure Health. This one is particularly used by those who are in the mental health or substance use recovery, and so they're more focused on those services. They also, just like the before ones, they also have services such as telehealth and billing. Just most of them, as we go through, you will find most of them have almost the same features, but towards the end, I can show you ways on what you should do so that you can choose the one most suitable for you. So if you check the website for Ensure Health, I can just show you also the website in a minute. So basically, this one will focus on therapy and those in rehabilitation process. Then we have Next Gen. Next Gen usually focuses on the use of AI in their tools and in their website, in their records. It can help in making an automated when you're trying to make a document an encounter with the patient. They can help generate a format in which so that then you can just fill up as needed, and they can help in charting. And you can good thing about it that you can access them after hours, like after the work hours, you can access them. They also have a tool you can use it in your phone so that you can check it up whenever you need. So this is their website. It has a lot of services. Then there is Athena Health. Athena Health is mainly used by those in the ambulatory care services, and they have a feature known as Athena One, which is an AI that helps you leverage all the ambulatory services and help improve patients' usability. I'll also provide, as before, we also provide. They also provide as medical records, electronic medical records, as well as like medical billing and practice management software. This is their website, Athena Health. They have used AI. Now, most of the modern website, all of them have the use of AI. Then finally, we have ModMed. This one is an all-in-one customizable software. This one also uses AI and provides specialty-specific EHR. Like this is like if your practice focused on one specialty, this one is the best one to go with, as they can provide a highly specific electronic health software, which is specific towards your specialty. They also help in data in patient analysis or any other analytic like billing, clinical workflow, and help to improve them. And this is their website, so you can actually choose what specialty you want, and based on that, they can provide you with the software best suited for that specialty. So briefly, I just covered those 5, but how do we choose which one is suitable for us? So first, we have to assess what our practice, what does it need? So we should evaluate our current workflow, pain points, and goals. We should consider our practice size, whether it's a small or large, or is it specialty? Is it primary care, or is it specialized care, or behavior therapy? And then what do we need from the program? Do we need patient scheduling, charting, prescriptions? And then also, it's a good idea to always involve the stakeholders such as physicians, nurses, and admins to gather input from them. Then we also prioritize key features. Like I said, most of them, they have very similar features, but some of them are better in others in specific factors. For example, usability. Some of them are very easy to use, while others are clunky. They have a lot of things in order to just write a note, you'll have to go through multiple steps, while others are just direct click, and you can chart much easier. Then some of them are rather rigid, while others are more customizable, so that you can add and modify as required. And then interoperability. Many of them, they allow for if the lab posts lab results, anybody in that anybody in that practice will be able to access them and see them. And then of course, they have to be secure. They have to be ONC certified, and they have to be compliant with HIPAA, and they should have strong data encryption to prevent others from to prevent identification of patient from outside. And then it should be integrated, so that it should be seamless with billing and revenue cycle management. And like Hafia said, most of them have tools that uses AI that can help inscription and telehealth. Then cost, of course, all of this software, they cost a lot of money. So some of them may be cheaper, but may not be what we want. So we'd have to check, analyze about their cost and see if they have any hardware or software training if needed. And then cloud-based options are usually they are more affordable if you have a small practice. Then we have to do our research. We have to check the request demos. We are, like I have shown in many of them give an option to show a demo, so we can just check the demos and trials, and then check other users what they have done on which one are they using depending on what on how big your practice is, and then verify the references from those who are having the similar practices as you. Then, then you finally go to the plant implementation, where you include data migration and staff training for this new program, and a contingency plan to have a ready plan if there is any form of disruption that may happen in the future. And that is all. Thank you for listening. Just wanted to be a short, brief presentation with the most importantly on how to select your program, as most of them are very similar to each other. So if at least if you take out if you just took away how or what on what basis do we select our program, that will be nice. Thank you very much. If you have any questions, I'll be happy to answer them in the chat.
Thank you so much, Doctor. Is there any question? Is my voice clear? Okay.
Yes, we can hear you.
Okay. We'll move on to the next topic. Thank you so much, Dr. Makkawi, for the great presentation. The next topic is going to be about the future of AI in medicine. It's going to be presented by Dr. Malaz Salah. Dr. Malaz, are you here? Yes. Are you ready? Okay. We can see your presentation. You can start.
Good morning or evening, everyone. My name is Dr. Malaz Salah. Firstly, I want you to imagine being on call. It's late, a patient suddenly deteriorates, monitors are alarming, the room is full, and everyone is looking at you. You do not have the luxury of time, you do not have complete information, but you still have to decide now. This is the reality of modern medicine. High pressure, limited time, and zero tolerance for error. So the question is no longer whether we can work harder. The real question is how we can work smarter. This is where artificial intelligence enters medicine. Not to replace clinicians, but to support clinicians, reduce uncertainty, and protect patients' lives. So today I will take you through how AI is transforming healthcare, what the future holds, and why understanding this shift is no longer optional for healthcare professionals. And to understand how we can work smarter in healthcare, we first need to understand what artificial intelligence is actually. Artificial intelligence in healthcare refers to computer systems that are able to learn from medical data, recognize patterns, and support clinical decision-making. These systems analyze large volumes of information such as electronic health records, medical imaging, laboratory results, and clinical notes. By doing so, AI helps clinicals improve diagnostic accuracy, predict risk earlier, and personalize patient care. So most importantly, AI does not replace doctors. It supports them. It acts as an intelligent partner, helping healthcare professionals make faster, safer, and more informed clinical decisions. Sorry. So before we talk about how AI is used in hospitals or clinics, we first need to agree on one thing. What do we actually, how artificial intelligence is working? AI is not a single tool. It's more like an umbrella that includes different technologies, each with a specific role. The three main tools we actually talk about are machine learning, deep learning, and natural language processing. So let's start with machine learning. Machine learning refers to algorithms that learn from data and use the learning to make predictions or decisions. In healthcare, this means we see the system patient data, such as age, lab results, vital signs, and the algorithms learns patterns from thousands or even millions of similar cases. For example, machine learning can be used to predict patient risk scores, like identifying patients at higher risk of readmission or complication. So machine learning is very good when we want predictions based on structured data. Deep learning is actually a more advanced subset of machine learning. It uses complex neural networks that are especially powerful in recognizing patterns that are difficult for humans to see. In healthcare, deep learning is widely used in medical imaging. For example, interpreting CT scans, X-rays, or MRI images to detect tumors, fractures, or subtle abnormalities. So while machine learning works well with numbers and tables, deep learning shines when dealing with images and complex patterns. Regarding the natural language processing focuses on helping AI understand and process human language. In healthcare, a huge amount of valuable data exists in unstructured text like doctor's notes, discharge summaries, and clinical reports, as we know. So natural language processing allows AI systems to extract meaningful information from these notes, such as diagnosis, symptoms, or treatment plans. So natural language processing acts as a bridge between human language and machine understanding. So now that we clearly understand what AI actually consists of, let's move to the next slide and see how these tools are applied in real clinical practice. So before know how it's actually AI is applying, there is very important question actually is coming in our mind. Why do we even need AI in healthcare? And why AI is actually now essential? Let me walk you through the main challenges that make AI is not just useful but essential. First, data volume. Healthcare generates an enormous amount of data every single day: patient records, lab results, imaging, monitoring devices, and clinical notes. This data is growing far beyond what humans alone can analyze efficiently. So AI helps us make sense of this data, turning raw information into meaningful clinical insights. So that means without AI, much of this data remains unused. The second challenge is rising healthcare costs. So healthcare is stretched, is increasing worldwide, placing enormous strain on national budgets and healthcare system. So AI can help optimize resource allocation, reduce unnecessary investigations, and improve operational insufficiency. In other words, AI supports smarter, not more expensive healthcare. Another major issue is clinical inefficiency. So, as you know, physicians today spend a significant amount of time on administrative tasks rather than direct patient care. So this leads to burnout, delays, and reduced quality of care. So AI tools can automate documentation, assist with clinical decision making, and reduce administrative burden. So this allows doctors to focus more on patients, not paperwork. Finally, there is a variability in care. Patient outcomes can vary significantly depending on location, available resources, and individual clinical experience. So AI can support standardized, evidence-based decision-making, helping reduce inconsistencies in care delivery. So this promotes more equitable healthcare across different settings. So when we put all of these together, massive data growth, rising costs, clinical inefficiencies, and variability in care, it becomes clear why change is necessary. And this is exactly where AI steps is not to replace clinicals, but to support better, safer, and more efficient healthcare. So in this slide, I will show how these challenges translate into real-world AI applications. To understand how AI is structured, we have to know the three main pillars. These pillars can help understand how AI creates real value, not just technology, not just technology help. These three pillars of AI in medicine. First is clinical outcomes. The first pillar focuses on clinical outcomes. AI its core. AI aims to improve diagnosis, treatment, and precision medicine. This includes early disease detection, more accurate diagnosis, and personalized treatment plans focused based on patient-specific data. Ultimately, this pillar is about better decision and better patient outcomes. So if AI does not improve clinical care, then it has limited value. The second pillar is operational efficiency. So healthcare systems are complex and resource intensive, as we know. So AI can automate administrative tasks, optimize supply chains, manage scheduling, and reduce unnecessary costs. This pillar focuses on doing more with the same or even fewer resources. So this means not only saves money, but also reduce burdens on healthcare professionals. The third pillar is patient engagement. AI can enhance accessibility, continuous monitoring, and patient health management. Examples include remote monitoring tools, AI-powered health apps, and personalized health reminders. So this shifts healthcare from being reactive to more proactive and patient-centric. So AI implementation in medicine is not random. It's built around improving clinical outcomes, increasing operational efficiency, and empowering patients. So with this framework in our mind, we can now explore real-world examples that demonstrate how AI operates across these three pillars. The first application is precision diagnosis, where AI acts as a clinical co-pilot rather than a replacement for the physician. Think of AI as an extra set of highly trained eyes. One of the highest strengths of AI in diagnosis is speed and volume. So AI systems can analyze thousands of imaging scans in a fraction of the time it would take a human decision. It would take time with a human clinician, sorry. So this is especially valuable in high volume settings such as radiology department or screening program. Faster analysis means faster decisions and reduced diagnostic delays. And another key advantage is subtlety detection. So AI can identify very small or early stage abnormalities that may be difficult to detect with the human eye. Examples include micro lesions or early cancers that may otherwise be missed. So early detection often means better prognosis, as we know. Also, AI models can also be trained on very specific pathologies. So that means it's specific. For example, detecting diabetic retinopathy or subtle lung nodules, this improves diagnostic accuracy and helps reduce unnecessary investigations. So that means the overall impact of this application is significant. And AI helps reduce false and negative rates, supports earlier interventions, and enhance clinical confidence. Importantly, the final decisions always remains with the clinician. And this image is it clear?
Yes, it is clear.
Okay. So this image, we can see how AI highlights a specific area in this X-ray concerning like using this bounding box or the overlays. So that means in the precision diagnosis, AI does not replace expertise; it amplifies it. So as we know, building on diagnostic support, let's move to another key application where AI improves how healthcare systems function day to day. AI is now helping us answer a critical clinical question. What is the best treatment for this specific patient? This is where personalized treatment comes in. Personalized treatment means moving away from the one-size-fits-all approach, and instead AI helps tailor treatment decisions based on each patient's unique genetic and biological profile. So, as we know, the one major application is genetic risk prediction. So AI can analyze genetic data to identify an individual's predisposition to certain diseases. So this allows for earlier screening, preventive strategies, and closer monitoring for high-risk patients. So instead of reacting to disease, we can anticipate it. Another important area is pharmacogenomics. So AI can predict how a patient will metabolize and respond to specific medications. For example, in chemotherapy, AI can help determine which drugs are more likely to be effective and which may cause severe side effects. This improves treatment efficacy while reducing harm. AI also supports treatment trajectory planning. That means by combining genetic, clinical, and environmental data, AI can recommend the optimal sequence and timing of intervention. So this means choosing not just the right treatment, but the right treatment at the right time. So in personalized treatment, AI transforms care from standardized protocols to individualized strategies. So the goal is better outcomes, fewer side effects, and more precise decision making. So far, we have seen how AI improves diagnosis and personalized treatment. Next, let's look at how AI transforms the operational side of healthcare systems. So as we know, AI is not only transforming clinical care, it's also revolutionizing how new drugs are discovered. This is what we call the discovery revolution. Traditionally, drug discovery is a long, expensive, and high-risk process, as we know. It can take more than 10 years and billions of dollars to bring a single drug to market. So AI changing this by cutting years off the discovery pipeline. This will gonna be through the following process. The first step is target identification. AI can analyze massive biological data sets, such as genomic and proteomic data, to identify and validate new therapeutic targets. This helps researchers focus on the most promising targets early. And the second is molecule synthesis. Next comes molecule synthesis. AI can diagnose novel de novo molecular structures with optimized properties. These molecules are designed to be more effective, more stable, and potentially safer. And instead of trials and error, drug design becomes data-driven. Another powerful application is a preclinical modeling. AI can simulate drug efficacy and toxicity before entering real-world experiments. So this dramatically reduces failed experiments and unnecessary costs, as we know. And this image shows how AI shortens the drug discovery timeline by accelerating early phases. AI allows promising therapies to reach clinical trials faster. So that means in drug discovery, AI transforms research from slow and uncertain processes into faster, smarter, and more efficient pipelines. So far, we have explored how AI supports diagnosis, personalized treatment, and accelerates drug discovery. Now let's move into one of the most advanced and sensitive areas of AI integration in healthcare, the operating room. This is where precision truly matters, as we know. AI-powered robotic system assists surgeons by enhancing precision and control. These systems can execute movements of a sub-millimeters level far beyond the natural limits of the human hand. Importantly, the surgeon remains in control while AI supports accuracy and stability. Think of AI here as a precision enhancer, not an autonomous surgeon. One key advantage also is micro-precision. AI-guided robotic system can perform extremely delicate movements, reducing tissue trauma and improving surgical outcomes. This is particularly valuable in neurosurgery, ophthalmology, and minimally invasive procedures, as we know. Another critical application is real-time navigations, as we know. AI analyzes live imaging, such as ultrasounds or intraoperative scans, to guide the surgeon dynamically during the procedures. This provides clear, precise boundaries and helps avoid critical structures. This significantly improves intraoperative safety. AI also enables creation of digital twins before surgery. So digital twins, as you know, is preoperative planning. So these are a highly realistic virtual models of a patient's anatomy. Surgeons can rearrange procedures in advance, test different approaches, and anticipate potential complications. So this transforms surgery from reactive execution to strategic preparation. In robotic assistance and intraoperative guidance, AI enhances precision, improves safety, and supports better surgical planning. So the result is more controlled procedures and better patient outcomes. So far, we have focused on AI within hospitals and clinical settings. But one of the most transformative shifts in healthcare is moving care beyond hospital walls. This is where AI-powered remote patient monitoring or AI RPM comes in. AI remote patient monitoring enables proactive care rather than reactive care. Instead of waiting for patients to deteriorate and present to the hospital, AI allows continuous monitoring and early intervention. So, firstly, through data flow. The process starts with data flow. Physiological data is continuously collected from sensors and ambient monitors. This data is transmitted to an AI platform in real time. So care becomes continuous, not episodic. And also intelligent interpretation. So AI algorithms can interpret this complex physiological data. Examples include heart rate variability, sleep quality, physical activity, and vital trends. So AI can identify subtle changes that may indicate early clinical deterioration. And then personalized baseline. One of the most powerful aspects is personalized baselining. So AI establishes a unique normal range for each individual patient. This allows the systems to filter out insignificant fluctuation and focus only on meaningful changes. So in other words, we can say the systems understand what is normal for this specific patient. And in this image, it shows how data flows from a wrist wearable or sensor to an AI cloud dashboard. So that means clinicians can then receive alerts only when intervention is truly needed. In previous slide, we saw how AI enables continuous remote patient monitoring. Now let's take this one a step further and see how AI moves from monitoring to prediction, prevention, and triage. This is where AI truly becomes proactive. So early crisis prediction, one of the most powerful capabilities of AI remote patient monitoring is early crisis prediction. So AI can forecast acute clinical events days before they actually occur. For example, predicting heart failure, decompensation before the patient becomes symptomatic. So this gives clinicians a critical time window to intervene early. And another key feature is smart alerting. And instead of sending constant alerts, AI prioritizes alerts based on clinical significance. This dramatically reduces alert fatigue for healthcare providers. So clinicians receive fewer alerts, but more meaningful ones. AI also driven monitoring plays a major role in reducing hospital readmissions. By enabling proactive intervention based on AI warnings, many unnecessary hospital visits can be prevented. So this improves patient experience and reduces healthcare system burden. And in this image, it shows how the dashboard interfaces a high-risk alert. It includes a predicted timeline for deterioration, allowing clinicals to act before a crisis occurs. So we can say AI-driven remote monitoring transforms care from reactive responses to anticipatory action. So the focus shifts from managing emergencies to preventing them. So far, we have discussed how AI improves clinical care and patient outcomes, but healthcare is not only about medicine, it's also a complex business with operational administrative challenges. So this is where AI plays a critical role behind the scenes. One of the biggest contributions of AI is automation. AI can automate medical coding, clinical documentation, and insurance claims processing use natural language processing. So this significantly reduces manual work, errors, and delays. As a result, clinicals spend less time on paperwork and more time with patients. AI also supports workforce management. So by analyzing historical data, and real-time demand, AI can predict staffing needs and optimize scheduling. So this helps reduce staff burnout and improves service coverage, especially in high-demand departments. So the right staff, so that means the right staff at the right time in the right place. Another important area is supply chain management. AI can forecast demand for pharmaceutical and medical supplies. So this minimizes waste, prevents shortage, and reduces unnecessary costs. During crisis, this capability becomes even more critical. And in this image presents how administrative processes are streamlined digitally in the background while the doctor focuses on the patient. AI quietly handle operational complex. So we can see operational efficiency powered by AI improves sustainability, reduces costs, and enhance the overall healthcare experiences. It allows healthcare systems to do more without exhausting their workforce. One of the most common concerns about AI in healthcare is this question: will AI replace doctors and nurses? The answer is very clear. AI is not here to replace clinicians. AI is here to augment them. So AI acts as a highly sophisticated decision support consultant. How? It provides evidence-based, rapid recommendations, but the final decision always remains human. So clinical judgment, responsibility, and accountability cannot be automated. And in decision support, AI helps clinicals process vast amounts of data quickly. So this allows faster, more informed clinical decisions, especially in complex cases. However, AI supports thinking. It does not replace it. Another critical role of AI is eliminating tedious tasks. So by automating data entry, documentation, and chart review, AI reduces a major source of clinical burnout. So that means there is less time on screens, more time with patients. And perhaps the most important benefit is restoring the human side of the healthcare. When clinicians are freed from administrative overload, they can focus on empathy, communication, and compassionate care. So these are things AI cannot replicate. So we can say AI augments clinical capacity by supporting decisions, reducing burnout, and protecting the human core of medicine. So technology becomes the background, human care returns to the foreground. Before we talk about the advanced AI models, we need to address fundamental truths. AI is completely depending on data, and this brings us to the first major challenge, which is the data challenge. So interoperability, why systems cannot talk. In healthcare, data is often stored in different systems that cannot communicate with each other. And electronic health records, lab systems, imaging platforms, and insurance databases often use incompatible formats, as we know. So this creates data cells where valuable patient information is fragmented across multiple systems. So that means when systems cannot share data, AI only sees part of the patient story. And the second is quality and cleansing, where is GuideGo comes in. This leads us to an essential AI principle known as GuideGo, which is garbage in and garbage out. What does GuideGo mean? GuideGo means that if the input data is poor, incomplete, or incorrect, the output, no matter how advanced the AI model, is also poor. So, for example, imaging training an AI model to predict sepsis risk. If the data contains missing vital signs, incorrectly labeled the diagnosis, or inconsistent time stamps, the AI will learn wrong patterns. As a result, the model may miss high-risk patients or generate false alarms. So that means advanced algorithms cannot fix bad data. And the third is why I need clean. So that means we have standardized our data. So AI models require data that is clean, standard, and accurately labeled. So this involves data cleansing, normalization, and quality control before model training. So without these steps, even the most powerful AI systems become unreliable. So necessary, we have data privacy. So data privacy and regulation is very important. So healthcare data is extremely sensitive, as we know, and regulations also of the and regulations such as HIPAA and the GDPR exist to protect patients' privacy. However, these regulations also add complexity to data storage, sharing, and AI development. So trust is not negotiable. Patients must know their data is protected. So we can say the data challenge is not just about volume; it's about quality, interoperability, and trust. And this is where Guy Goro reminds us that AI is only as good as data we feed it. Another major challenge in applying AI to healthcare is algorithmic bias. So this occurs when AI systems unintentionally reinforce existing healthcare inequalities. So, and this is not a technical issue alone, it's also a social and ethical one. So, skill training sets. AI systems learn from the historical data. If training data is drawing predominantly from one demographic group, and the model will perform better for that group and worse for others. For example, if an AI diagnostic model is trained mostly on data from ethnic population, it may fail to accurately diagnose patients from underrepresented groups. So that means the bias is not in the algorithm, it's in the data. And we have perpetuating bias. So biased algorithms can perpetuate and even amplify existing disappearance. So this may lead to underdiagnosis, delayed treatment, or inappropriate care for monitoring population. So in healthcare, this can have serious and life-threatening consequences. So an inaccurate, as we know, prediction is not just an error, it's a patient safety issue. So we have mitigations algorithm. Mitigating algorithmic bias requires deliberate and proactive strategies. This includes diverse and representative data collection across population. It also requires continuous auditing, validation, and monitoring of AI models after deployment. So that means bias mitigation is an ongoing process, not an one-time fix. So we can say algorithmic bias remind us that AI systems reflect the data, decisions behind them. Responsible AI requires fairness, transparency, and accountability. And even if AI systems are accurate, fast, and powerful, one critical question remains. Can clinicians trust decisions they do not understand? This leads us to the black box problem. Many advanced AI models, especially deep learning systems, operate as black boxes. They provide predictions or recommendations without clearly explaining how those decisions were reached. In medicine, this is a serious issue. Clinicians need to understand reasoning behind a decision before acting on it. So this is why explainable AI or XAI is essential. So explainable AI or XAI requires AI system to demonstrate how and why a decision was made. This allows clinicals to assess whether the recommendations makes clinical sense. And we have to remind transparency builds trust. And regulatory compliance. Regulatory bodies such as the FDA require clear evidence of safety and efficacy. So AI systems must validate it, monitored, and continuously evaluated before and after deployment. Without explainability, regularity approval becomes extremely difficult. If a system cannot explain its decisions, it cannot be safely approved. So what about liability? Another major concern is liability. If an AI-assisted error occurs, who is responsible? Is it algorithm, the developer, or the physician who used it? So without clear accountability, we have to remind that without clear accountability frameworks, AI adoptions becomes risky. So that means the black box problem highlights that accuracy alone is not enough. Trust, transparency, regulation, and accountability are essential for safe AI integration in healthcare. So as AI becomes more integrated in healthcare, we must pause and ask an important question. How do we ensure that technology enhances care without compromising our humanity? This brings us to the ethical and societal considerations of AI in healthcare. As we know, patients have the right to know when AI is involved in the healthcare. Informed consent means clearly communicating to the patient how AI is being used, what role it plays, and its limitations. So transparency builds trust and empowers patients to participate actively in their care. So AI should never be invisible to the patient. We have to remind. And the other risk is dehumanization. So over-reliance on technology may reduce meaningful human interaction between clinicians and patients. So healthcare is not only about accuracy, it's also about empathy, reassurance, and human connection. So AI must support care, not replace compassion. AI will change, AI will change how care professional work. So this makes workforce training essential. AI fluency should be integrated in medical education and residency programs. And the goal is not to turn clinicians into data scientists, but to help them safely and confidently work alongside AI. So an untrained workforce is an unsafe workforce, as we know. And here in this image represents the balance between the human connection and digital systems. It reminds us that technology should always remain in the background, supporting, not replacing human care. And when we talk about the future of AI in healthcare, many people imagine something distant or experimental. But the reality is very different. Most of the changes driven by AI are not decades away. They are expected within the next 1 or 3 years. One of the most immediate milestones is widespread AI-based imaging triage. So AI will be delayed across nearly all major radiology and pathology departments. Its role will be prioritize urgent cases, flag abnormalities, and support faster reporting. So this means critical cases are reviewed first, reducing delays in diagnosis. And also the AI remote patient monitoring adoption. Another major milestone is the rapid expansions of the AI-powered remote patient monitoring. We will see significant growth in personalized continuous monitoring, especially for chronic disease and post-discharge patients. And that means this will shift care from hospital-based to home-based settings. So that means the care becomes continuous, proactive, and personalized. And also automations of administrative workflows. AI will become standard in administrative operations. So routine tasks such as medical coding, clinical documentations, and claim processing will increasingly be automated using the natural language process, as I mentioned before. So this reduces cost, errors, and administrative burden. So that means clinicians spend less time on paperwork and more time in patients. So in this image is showing the roadmap and highlights these milestones are not a separate development, but a part of coordinated transitions. And in near term, we saw how AI becomes part of everyday clinical operations. Looking further ahead, over the next 4 to 7 years, AI will move from support tools to deeply integrated precision systems. So this is where AI starts to reshape how decisions are made across the entire healthcare pathway. So integrated electronic health record AI systems. One major milestone will be the full integration of AI into the electronic health records. And as we know, the electronic health record system will no longer be passive data priorities. So instead, AI will be seamless embedded, providing real-time predictive analytics during the clinical workforce. So that means the clinical will not need to ask AI insights, will appear automatically at the point of care. And the second, we have the digital twins. Another transformative development is the routine use of digital twins. So digital twins are virtual patient models that stimulate anatomy, physiology, and disease progression. And these models will support drug selection, treatment planning, and even pre-surgical pre-erasal, as I said. So that means instead of guessing how a patient may respond, clinicians can simulate outcomes in advance. Also, AI discovers therapies. AI will also play a larger role in therapeutic discovery. Within this time frame, the first generations of the fully AI designed molecules is expected to enter phase 3 clinical trials. So this represents a major shift in how new treatments are developed. So that means drug discovery becomes faster, more targeted, and more data-driven. And this image is show the concept of a digital twin displayed alongside of a real patient. So it represents the transition from population-based medicine to truly individualized care. And this slide is represents the long-term vision for the AI in healthcare, looking 8 years and P1. This stage, AI moves from being supportive to becoming truly transformative. So transformative vision, autonomous, and proactive health. So that means healthcare will shift from a reactive model to a proactive one. So instead of waiting for disease to appear, AI systems will continuously monitor health and intervene early, sometimes before symptoms even begin. Autonomous diagnostics in the long term, AI systems will be capable of independently diagnosing certain well-defined diseases with minimal human oversight. So that means a physician will remain responsible for the supervision and final accountability, but AI will dramatically accelerate accuracy and decision making. So that means personalized preventive health, AI-powered continuous health monitoring will allow prevention strategies to be tailored to each individual. So this means personalized risk predictions, early intervention, and in some cases, through disease prevention or significant delay in disease onset. And also global health equity. Perhaps most importantly, AI expertise will be deployed affordably across the world. So advanced diagnosis and decision support will no longer be limited to the health resources settings, helping reduce global health care inequality. So to conclude, the future of AI in medicine is not just about adapting new technology. It's about investing in an augmented future of the healthcare. AI has the potential to become the transformative tool needed to address many of the challenges facing modern healthcare system, including workforce shortage, rising costs, and increasing clinical complexity. However, success is not automatic. It requires a strong ethical governance, investment in high quality and diverse data, and close interdisciplinary collaboration between clinicians, engineers, policymakers, and researchers. So this brings us to the call to action. We must champion responsible innovation, invest AI literacy for clinicians, and ensure that every AI tool introduced into the healthcare keeps the patients at the center of care. Ultimately, if we approach AI thoughtfully and ethically, it will not replace human care, it will strengthen it. So together we can build a safer, smarter, and more equitable future for healthcare. Thank you so much. Anyone have any questions?
Thank you very much, Dr. Malaz, and all the speakers. Thank you. Any questions for Dr. Malaz or any other speakers? If not, we have a couple of announcements or updates. Anyone with any updates as far as your projects, your ideas, please raise your hand or let me know. In the meantime, I'm going to share with you, I think one of the fellows presented a poster, so next week, hopefully, we'll hear from her back, Dr. Das. And tomorrow there will be like a seminar about step 3. So if you have a minute, you can look at that. I'm going to share the screen here with you guys. So basically, if you go to step 3, transitional or the alert, it will give you the link and you can register for tomorrow's meeting. It's going to be just, I think, more information about the timelines. If you plan to take step 3, hopefully it will help some of you guys. Also, we have the conference for AMDA, or post-acute and long-term care, that would be in March. So they're accepting abstracts, and the deadline, I think, in the first week of January. So a few days or more than a week. So if you are interested, maybe you can do some of this. So I'm gonna ask you, this is about the board. There is a new board certification for IMG rules. So this website here share how is the new requirement, so that if you are here in the US and you want to be board certified in internal medicine, there is a pathway where you can go into that. So you can find more information about that in the app, and it will link you to this website here in LinkedIn. The final thing I want to share with you is, if you have your phone ready, maybe you can scan this barcode. So this is an idea of educational material, but we want to create an abstract that we can submit to the AMDA, the American Medical Director Conference. So if any of you is interested in geriatric medicine, internal medicine, family medicine, you can add your email in the chat right now, or if you want to share with others who might be interested. So the idea is for the IMGs, the training about fire drills and fire knowledge, education skills, and avoidance of the risk will not be as available, or education gap is there. So we want to cover this gap, especially for any international medical graduates who will join a residency. They will be working at hospital or other facilities like nursing homes. So they need to understand the concept of fire drills and how to manage any events if it happens. So this app, if you want to use this QR code, it will ask you just to see your baseline knowledge about what the steps and what's the role, and what's your knowledge about the basics of the drills, and why we need to be ready. And then it will provide you with some educational material, some videos, short videos, couple of minutes videos, or some slides that will explain things for you as a participant. And then there is a post-test like questionnaire. It will have similar questions and maybe some elaboration about what you learn. And this will help us see if this material will be useful for IMGs. So if you are interested in looking at this data and analyzing it, and maybe submitting it as an abstract to AMDA before, I think it's January 6th, please add your email in the chat, and then I'm going to share with you the data when we collect it, and then we can do some analysis and write an abstract and then submit it. Hopefully it will be a good opportunity. Usually we will have a number of fellows interested in similar activities. So if we have a lot, we can create more than one abstract using same data or same concept regarding what need to be done as far as educational material, maybe building curriculum. So we can help fellows or in this program, or even other international medical graduate be ready. And the reason this is important, because in last week, I think a few days ago, one of the nursing homes in Pennsylvania had a leak, gas leak, ended up in a fire, and one patient died, and one employee, nursing assistant employee, died as well. So to prevent this from occurring, and be ready to help your patients, yourself, and others in the building where you are training, or it's important to know the steps that will help everyone. Any questions? Thank you. So I'm gonna identify some of you to work on the abstract. I'll give you the information. You can build the abstract and the data analysis, and we'll see who will be able to submit and do all this. So if you are interested, please add your email in the chat. That would be great. So this is the QR code again. If you are interested in answering the questions, study the material, the educational information, and the skills, and you can ask others to do the same. And if you are done, you can do the post test questionnaire again. Thank you. If no more questions, I'd like to thank you so much, Dr. Omar, and all the presenters. You did a great job, excellent, wonderful, and thank you for your effort, your great presentations and teamwork. And I'd like to thank all those who attended today's meeting. Thank you for your time, and thank you so much for getting involved in this program. And also many thanks to those who will come and watch the recording in the future. We'll see you next week. If you have questions, please let me know. You can email or send me a text or WhatsApp or call. I'll be happy to help as much as we can. Thank you so much, everyone. Have a wonderful day or night. See you next week. Assalamu alaikum.
Alaikum assalam. Thank you, Dr. Nadir. And thank you
Thank
for
you.
this app, Fire app. Thank you very much.
You're welcome. Thank you.